Thank you very much. Thank you for coming. For those of all of you that you didn't finish lunch, please share with me. I will be very happy to share your lunch. So I have my coffee at least. So I was given 20 minutes to talk about 25 years of experience. So people that gave me that time, they might think that I do nothing in life because I don't know how I'm going to condensate 25 years in 20 minutes, but I will do my best. So here, so we'll talk about how do we study patients with primary immunodeficiencies plus minus immune dysregulation. I will focus more in patients with PID, the different cell types, the different pathways, and then Adriana are going to talk more about autoinflammation. So, but talking about PID, so PIDs, that is not pelvic inflammatory disease in our world, is primary immunodeficiencies. So the incidence is between 1 in 100. If you think that everybody that gets infected has a PID, so it could be 1 in 1,200. If you pick up the phone and you call people and say, do you have a PID? Yes, that's it. That was published. That was one of the numbers that was really published. And 1 in 10,000 is probably more realistic. Those are the people that they have an immune deficiency, a genetic defect, and they have clinical symptoms. So there's more males than females. So we were awarded with the benefit of having more PIDs. And the distribution is depending on the cell that they are affected. So B cells or humoral deficiencies, combined T and B, T cell deficiency in phagocyte and complement, and we'll try to dissect. So each cell type, each pathway, how do we analyze them, and which are the markers that we use to define the integrity of those pathways. So, but as a rule of thumb, as a rationale, what we do, this is the basis of how you study patients with PIDs. First, you look for cells presence and enumeration. That they are present is not enough. They have to be present in the right number according to the age. The cell function, so nothing goes, just the presence is not enough. So presence has always to be coupled with function. And the same applying to proteins. The protein has to be present and it has to be in quantity, the right amount of the protein, and also protein function. And then we have genetic analysis that we will not discuss today because that was already very clearly addressed by Hal Hoffman and by Ivona Ksentikiewicz. So what I'm trying to tell you is everything that we're going to discuss here is going to be related to quantity and function. Quantity and function, both of proteins plus minus cells. The most common PIDs are the ones that they affect the B cell compartment. So here you can see I have just told you that you always will have to evaluate the quantity and the function. You evaluate quantity of immunoglobulins, it's going to be the levels of IgG, A, M, E, and D. Subclasses, mostly useless, unless you are thinking of IgG4 deficiency. In general, think that IgG4 is deficient in 1/10 of the general population. So unless you are thinking of increased IgG4, it's not a very practical test to do unless you are doing something very peculiar or particular. So then white blood cell counts and differential to count the B cells, lymphocyte subsets that we'll discuss a little bit further. And then we go into the function, natural antibodies, protein antigens to evaluate polysaccharides, and class-rich studies. Let me go point by point because these are the most common defects. This is the arm that is most frequently affected in the world of primary immunodeficiencies. Immunoglobulin levels, so you have to check for age-match control. So it's not the same thing to be in a newborn to be in an adult. So newborns, as you will see now, so they have very low amount of IgG because they don't produce it. It takes them 6 months in order to start producing. Everything that we get when we're newborns is because of mommy is good enough to give us a lot of IgG through the placenta. Then we lose that one and we start to produce our own. So normal ranges, people insist that they are in standard deviations. This is essentially wrong. So the distribution of immunoglobulins is not Gaussian. So we prefer to use 95% confidence intervals. So we are not use standard deviations, but still we use between the minus 2.5 to plus 97 interval confidence because those are the ones that are going to give you the 95% interval confidence. Half-life are different immunoglobulins have different half-life, and the total immunoglobulin level is a net of production, consumption, and loss. Just a tip, is not a bad idea whenever you think that the patient is hypogam to check albumin, because patients that they have nephrotic syndrome, they have low IgG and they have low albumin. So keep in mind that if you're losing, peeing or pooping a lot of protein, you might lose them, but it's not because you are immunodeficiency. It's because you have a big hole in your kidneys or in your GI tract. So here is what I was telling you before. So when we are born at this point, mom, during the last trimester, she gives us a lot of IgG because she knows that we'll not be able to produce them in the first 6 months of life. So here is maternal IgG goes down as our own start to goes up. IgA is totally ours, IgM is totally ours, IgG in the first months of life, it belongs part to us, part to mom. So keep that in mind if you are going to do serological testing, because you might be evaluating the mom rather than the patient. If you evaluate anything that is IgM, you know it belongs to the baby. Specific antibody responses. This is a very important point because it tells us about the integrity of the whole system. So there are different ways of evaluating the humoral compartment. So represent the standard regarding the capacity to mount antibody responses. Natural antibodies, for example, isoagglutinin. So those are antibodies to the blood type that we don't have. And they depend on the diet, and it depends on the microbiome. So depending on the different flora that we have in our GI tract, so we're going to recognize certain antigens better than others. If we are group A, we'll mount antibodies to group B. So if you're group B, you'll have anti-A. If you're O, you have anti-A and anti-B, and you're AB, you will have no isoagglutinin. Those are IgM, and it's a way of telling you that your immune system is recognizing polysaccharides. Then you have the provocative testing, and this is kind of the most provocative approach that we can take. We draw blood, we measure antibodies to, let's say, tetanus toxoid, we give the patient the vaccine, and 2 to 6 weeks later, we reevaluate the mounted immune response. Why this is the gold standard? Why this is the most important test that you can do? And here I will try to convince you why. First, you give the vaccine, then you have antigen-presenting cells that are going to present the antigen that from being this shape, it's going to become in a different shape that are going to present it in the context of HLA. T cells are going to recognize those antigens in the context of HLA. They're going to produce IL-2, they're going to respond to IL-2, they're going to proliferate, they're going to interact with B cells that they recognize the same antigen that has changed its shape, now it's a native shape. Those B cells are going to also proliferate, going to become plasma cells, and going to produce antibodies directed towards the antigen or the vaccine that triggered the response. If you draw blood and somebody has 0 antibodies towards this vaccine, and after 4 weeks after giving the vaccine, it has 100, it means that the patient, first, you gave them the right vaccine. That's important. Then the patient has antigen-presenting cells. The patients know how to process antigen. The patient expresses HLA. The patient has T cells. They produce IL-2 and respond to IL-2. Those cells can interact with B cells that they're present. Those B cells are able to recognize the antigens. They can proliferate, differentiate into plasmablasts, and then into plasma cells and produce immunoglobulins. If you have a positive 0 to 100, everything here is fine. If you have a problem, it might be because you gave the patient the wrong vaccine or doesn't have antigen-presenting cells or have no T cells. But whenever you have a normal titers from 0 to 100, and I'm making those numbers up, it means that all this pathway works fine. And that's why it's such an important test. Other thing that there's some confusion is when we test protein antigens or conjugated antigens. Whenever we test antigens that they are purely polysaccharides, we have B cells that are going to make plasma cells, and they're going to produce IgG2 and IgM mostly. There are going to be no memories, there are going to be no T cells involved here. Whenever we're using conjugated vaccines, here the B cells are going to recognize the polysaccharide, but then they're going to process the antigen, the protein antigen, it's going to express this in the surface, and they're going to interact with T cells. That means that then you will become memory B cells, and instead of producing IgG2 and IgM, you are starting to produce IgG1 and IgG3. So you are tricking the immune system between responding just as a pure B cell response to a T cell dependent response that has memory. So that's not a minor issue. That makes that 20 years ago, 30 years ago, we were seeing patients die because of Haemophilus influenza meningitis, and now we don't see that anymore, except for the Baxters, so that we don't see that anymore because now we have these kind of vaccines that they trick the immune system and they help us to respond to that. So that small trick changed the epidemiology of the world. Now, how do we evaluate the B cells? So here you have a patient that immunophenotyping in an infant with bacterial infections and no tonsils. So here you have flow cytometry. We're evaluating CD3, that's a marker for T cells. We're evaluating here CD20, that's a marker for B cells. Here you have a lot of T cells that are CD3 positive. Here you have cells that they are non-T, non-B. Those are usually NK cells. And here you have nothing. This patient has no B cells. Very likely this patient to be a BTK patient with no B cells. So how do you classify, immunophenotype the patient with B cells? There are multiple forms. One of the most classical is using IgD and CD27. CD27 is a marker of memory. IgD is a marker of switching of the immunoglobulins. So using those two markers, you have 4 quadrants, and that's why you hear often switch, non-switch, memory, non-memory B cells. So that comes from this kind of combination. But this is an ultra-simplified way of doing it. It's the one I like, because the other one that I don't like is like this. All those markers can apply to B cells. I don't know what they do. And I'm an immunologist, so we're in trouble now. So if I don't know, you're in trouble too. But let me tell you, with the other ones, we are okay. We can survive with the other ones. But keep in mind that all the B cell markers, they are not there forever. So for example, CD19 is always there, but CD20 is not present at the very beginning or at the very end. That can play in our advantage. When we use Rituxan, we don't kill the plasma cells because they do not express CD20. So keep that in mind, that whatever biology does, it can be used in our favor. So we know that we want to kill these cells with Rituxan, but we don't kill these ones and we don't kill these ones. And this applies to different markers that we have on B cells. T cells. So again, we have to use white blood cell counts and differential. This is important because whenever we're doing the typification or immunophenotyping of T cells, you want to know, when you do flow, you get percentages. Oh, you have 70% of T cells, that's fantastic. But if you have one T cell, who cares? 70%. So that's why the CBC is important. So whenever you're doing flow cytometry, keep in mind that you have to count the absolute numbers. Percentages are great, but 70% of 0 is still 0. And I passed elementary school, so I know that. So please remember that. Flow cytometry without CBC, nothing, useless. So lymphocyte subsets we'll discuss. There are multiple of them, and we have CD3, CD4, memory, TEMRA, effector memory. So we use different combinations that they help us to define different functions. And again, we can use, these ones are the ones that we prefer. So CD45 array are naive cells, a row are memory, and we use CCR7 or CD62 ligand, again as a marker of naiveness or non-naiveness of the cells. Functions, they're tests that we don't use anymore, but it's not because they're not good, it's because we became lazy. So delayed type hypersensitivity, so candida, tetanus, PPD. So you have to have been exposed before, and then you check a reaction in the skin. No patient with a severe combined immunodeficiency has a positive DTH. So that's the power of those tests. Even we don't do them anymore, they're still great tests. Now we move to something that's more standard, like lymphocyte proliferation, TREX, T-cell receptor excision circles, and cytotoxicity assays that we'll discuss now. So here we have another patient that's going to trigger the discussion how we evaluate the immune system. So here is an infant with opportunistic infections and failure to thrive. Here you're using CD3 in the y-axis, 19 as a marker of B cells, 56 as a marker of NK cells. You can see here the control individual. T cells, lot of T cells, 19, lot of B cells, NK, lot of NK cells. The patient has T positive, B positive, NK positive. That's good. Look about the patient. So CD3, nothing. B cells, yes. NK, no. So this is how we classify, in a very easy way, our severe combined immunodeficient patients. T minus, B plus, NK minus. And the most common form of this is the X-linked recessive disease, the severe combined immune deficiency due to mutations in gamma C or CD132. But let me tell you one trick. Not always believe what you see by flow cytometry, or believe but with a grain of salt. Here you have a control individual, flow cytometry for CD132, isotype control, We want to see how sticky the cells are for the antibody. And here you have the control, express CD132. Here you have a patient that isotype control. Here is the analyte, and it's almost negative. So that's perfectly fine. But here is a mutation-proven patient that we know that is a SCID, but expresses the protein. This happens with missense mutations. So keep in mind that you see the protein there doesn't mean that it's working. And this is to reinforce the idea that whenever you are doing certain tests, you have to know what can you expect from those tests. Flow cytometry will not tell you the protein is there. It will not tell you in this approach that the protein is working. Make sense? Please, one yes. Yeah, okay. Thank you very much. So now here, things that we're getting closer to your heart. So now here, we are talking about different subsets of T cells. So here we have Th1 cells that usually mediate cell-mediated immunity, and we usually define them by the presence of interferon gamma. They have interferon gamma inside, and they secrete it. The same way, we look for Th2, that they help the human immunity, and they produce certain cytokines, including IL-4. And we want to see how much they produce to help us to discriminate that. We have Tregs, T regulatory cells, that usually they have specific markers in their surface or in the cytosol, like FOXP3. And here we have Th17, that they produce IL-17. So then we do flow studies that help us to define all those populations. So you don't have to guess, so you can define how many of those cells your patients have. So Th0 and Th1, they produce IL-2. You have here control 1. That's another thing. One control, BS. You need more than one control. One control could be an outlier. You need more than one control. So here you have control 1, control 2, control 3. All of them have IL-2. And this patient also is producing IL-2. So it means that the patient has Th0, because Th0 cells, they do produce some IL-2, and probably also Th1. But look, when we were using interferon gamma and IL-4 to discriminate between Th1 interferon gamma, Th2 IL-4. Here you have the control 1, control 2, control 3. Our patient doesn't have them. So it means that the patient, even was producing IL-2, doesn't produce interferon gamma as a marker of Th1, doesn't produce IL-4 as a marker of Th2. And the same thing happens with Th17. Here you have, it's a smaller population, but it is there. You can detect it, IL-17 in control 1, 2, 3, it's absent in our patient. This is a real patient, I'm not making that up. I make some things up, but not this patient. Here are the cells that you like. So here you have Tregs, T regulatory cells. There are different ways of evaluating those cells. The markers that most of the people agreed kind of the gold standard is FOXP3 and CD25. If you are CD3, CD4, FOXP3 positive, CD25 positive, you have Tregs. If you are an IPEX patient, you may be negative for those markers. And this is the ideal case. It's not always that clear, but this, for a presentation, you look for clear-cut patients. Then we move into the function. So how do you make the T cells work? So here you have lymphocyte proliferation. We have the old method that we're using titrated thymidine. So it took radiation. Nobody wants to deal with radiation anymore. Not Iran, no Trump. Nobody wants to deal with radiation anymore. So not us either. So now we're moving to different methods that they don't use radiation. But this is kind of the gold standard. Titrated thymidine, so you reproduce the cells, and then you put titrated thymidine that it's radioactive. So whenever the cells are dividing, they're making new DNA. And they're going to use their radioactive DNA in order to make the new DNA. So when you measure radioactivity at the end, if the cells are radioactive, it means that they were using radioactive nucleotides. So that's kind of the principle. But now we move to a different method. So now we load the cells with dyes inside the cell, and we say, dye, stay there. And when we order the cell to reproduce, it's going to divide, and the cells now will have 50% of the dye because it doesn't get out. And with these daughter cells divide again, each cell is going to have 25% of the dye. So you can track each cell how they divide. So here is how it looks. So flow cytometry usually is left to right. So CFC, this method is like Hebrew, is right to left. So here you have to start looking at the right. So here's all the dyes inside the cell. And here, each peak is a cycle of division. So here you can track how cells divide, and actually you can look how CD4s and CD8s, divide. So before, when you use titrated thymidine, you have PBMCs. Here, you can track each cell, how they divide. So it gives us another layer of information, not the bulk information about division. Here, you can track it by cells. Cell cycle, that's another thing that has been associated with particular prime immunodeficiencies. So here you have, if you remember from high school and med school, you have the G1, where the organelles double, then you have G0, synthesis, G2, and then the metaphase. And you can track that by flow. And here you have a control. Here you have like almost 50% of the cells are in G0, G1. And here you have the S phase, 24%. And here you have the G2 and the mitosis, 14%. You can see how different the patient is from the control. Phagocytes, I'm going to go a little bit faster because I want to go to things that are more relevant to you. So here you have DHR for CGD patients. So here you have, again, you put a dye inside. Whenever this dye is in contact with reactive oxygen species, it becomes from no color to a color. So here you have a healthy control, that this is when the dye has a color, and this is a patient that obviously, because they produce no reactive oxygen species, the dye doesn't change its color. So this one is a form of the disease, it's autosomal recessive, is not as severe as this one, so it means that they shift a little bit, but not that much. And this is an undecisive individual. Those are females. So they have 2 X chromosomes, and they don't know what to do. They want 2. I say, I want 2, I want 2, I want 2. Okay, here you have 2 X chromosomes. What are you going to do? I'm going to inactivate 1 each time. So here, when the patient inactivated the wild type, so she has all the cells that they're sick, they're not producing reactive oxygen species. And this is when that she inactivated the mutated one. So females, because they have 2, you can track the X chromosome activation doing this test that's called DHR. This is another disease, more rare, leukocyte adhesion deficiency, expression of CD18. NK cells, I'm going to move forward. Very interesting cells. And here you have multiple cells of NKs. So you have the ones that they produce of a lot of interferon gamma and the ones that they are cytotoxic. There's one thing that's a very interesting functional test that's called CD107A. So CD107A is inside the cell. When you stimulate the cells, and you use an antibody and you don't permeabilize the cells, you cannot detect CD107A. But whenever you stimulate the cells and those granules open up, so then you're able to detect them. So here where you're looking for an antigen that is inside the cell, they're going to come up whenever the cells undergo exocytosis. So here you have the control. When we stimulate the cells, we're able to detect CD107 in the surface in a patient with a problem like Chiriakigashi, Griscelli, so they cannot do that. So this is a very interesting functional testing. Complement, you know better than I. You have C3 and C4, and then you have the ones that evaluate pathways by themselves. But I want to show you things that are closer to your normal practice. So here, JAK-STAT pathway. We can evaluate that pathway, and that can be useful for you to monitor your patients on JAK inhibitors. So here, you have a normal individual. We stimulate with IL-6, IL-21, interferon alpha, and we were looking for STAT1 phosphorylation. And here you can see, here's the healthy control, this guy. Here's the patient with a gain-of-function mutation. You can see that the red one is overshift to the right. When you put those patients on JAK inhibitors, that red signal should come back to the normal individual. You don't want the guy to be negative, because you don't want to make them have a null mutation or null. You want them to be just as normal. So this is important because that can help you to monitor your patients. Here, you can see how broad you can go. I was showing before IL-6, IL-21, and interferon gamma. Here you can use it with IL-2, with IL-7, 15, 6, 21, 4, another patient with STAT1 gain of function. But again, this is a very powerful test because it helps you. First, it tells you that even if JAK1 is a STAT1 gain of function, you can see that other cytokines and other readouts are also affected. So even we like to call them STAT1 gain of function, they affect multiple other JAKs and STATs. The other one, the NF-kappa B pathway, another one that's close to your practice. So the both pathway, canonical and non-canonical. One of the methods that we use is we check for I-kappa B alpha phosphorylation and degradation. You stimulate the cells, you degrade I-kappa B alpha, and then it starts to come back. Here is kappa B alpha, you degrade it, and it starts to come back. So you can do that in order to test patients that you think that their NF-kappa B can be overworking or underworking. Most of the time, in your case, they're going to be overworking. The other pathway that is going to be interesting to evaluate, PI3 kinase. So PI3 kinase is involved both in B and T cells, and it can be evaluated again in T and in B cells. So this is a little bit more complex laboratory-wise, but it helps you to monitor patients, especially if you put them on mTOR inhibitors, because you know that they're going to be gain-of-function mutations. You put them in mTOR inhibitors, and you will going to get a signal that's going to be decreased. So, to conclude, just half an hour late, but you know, I'm now in good company. I guess that everybody over talk. So here, cell presence and enumeration is important, but the function has to couple wherever you look. Protein presence and quantitation, but protein function. You already know about genetic testing, but this is probably more important than everything else I said before. No diagnostic tool will solve all your patients' challenges, or more important, will replace clinical knowledge. So no, you can have whole genome, whatever, transcriptome, blah, 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 and if you don't think your patient's straight, you will get nothing of those tests. So use your mind, think about your patients. There are plenty of tools. They will help you to solve your patients, but you have to know what are you looking for. This is the team. So this is the team that works. I take the credit, and thank you very much.